longtime member of the Evidence-Based Services Committee. So
This pen might be better.
So I'm just going to kind of kick things off today. We're going to hear, I think, some really exciting information about a project that's been at Candy for going on 5 years. It's called Project Laulima. It's a grant-funded project funded by the Federal Substance Abuse and Mental Health Services Administration. And I was asked to sort of talk for a minute about where PL came from. And that was a little glint, I think, in Dr. Michael's eye, where we were presented with the possibility of applying for a system of care grant, which we've done several system of care grants, so we kind of knew what we were doing with that. And the question was, okay, we've got a project going for girls who've experienced trauma and we think need specialized care. What's another group that we really think we could do something better for? And I think it was Stan initially who said, could we do that gap group, the gap group? And that gap being the youth who have some kind of intellectual disability, developmental issues, and co-occurring mental health challenges. And particularly in our state, we've been challenged by the eligibility criteria for our developmental disabilities waiver, which makes the requirement to get services from our developmental disabilities division particularly difficult to meet. That is, you have to have a level of functioning that's 3 standard deviations below the mean, whereas in most states it's 2. So we had Candy saying, we can't serve youth with intellectual impairments. And then we had developmental disabilities saying, we can't serve youth unless their developmental disability is in the moderate range. So it meant that all of the folks in the mild range of intellectual impairment were just getting nothing as far as the Department of Health was concerned. So I think we had several.
So let me know if you can't hear me. How does that look? Does it need to be focused a little bit more? Okay, that's better. All right, how about this? Okay. So I just wanted to give you a brief overview of what we're going to cover in the presentation. Dr. Slavin gave us a little bit of an overview of why the grant proposal for Project Laulima was written. I'm going to give you an overview of the project and talk about our different primary areas of focus. And then Sue is going to talk about a couple of our direct services, our solutions HUI and our specialized care coordination in more detail. And then Ada is going to present data from our comprehensive behavioral intervention program. And then Kat is going to talk about some successes and challenges with CBI, as well as some of the interventions used in that program. And we also will have a family coming to chat with us, I think, around 4:30 to talk about their experience in the CBI program, which is very exciting. And then I think we have time for Q&A. All right, so Leslie talked a little bit about this already, but Project Laulima is a SAMHSA-funded program, the Substance Abuse and Mental Health Services Administration. It's a system of care expansion grant, and what we're really focused on is systems change and developing infrastructure for better coordination among systems. So providing direct services is one part of the program, but a lot of what we do is really around developing partnerships and building coordination across the system. Because I think what we've heard is that historically a lot of the child-serving agencies were kind of working in silos. So a lot of what we want to do is increase coordination to help families and youth who are working with many different organizations within the system. So we provide specialized care through our direct services, but we're also trying to increase coordination. Leslie said this already, but we started off as a one-year planning grant, and we then received 4 years of implementation funding. We're now in our 4th year and have one more no-cost extension year to go. So we have 5 primary areas of focus for our system of care expansion. The first area is community outreach. We're always working with communities to talk about the programs that we're putting into place, but more importantly, to really hear from community members about what the priorities are, what they feel the needs are in terms of the programs that we need to implement and the trainings that we need to implement. We're doing a lot of work around training and capacity building as well, and now that we're approaching the end of the grant in its current state, this is where we're focusing a lot of energy right now. And a lot of what we've done over the past few years has been around training, but we're really thinking about sustainability now, and what we can do to increase capacity in a sustainable way. We also provide direct services, so our Solution SUI and specialized consultation services are what you're going to hear from Sue about in a little bit. I'll give a little overview during my presentation, and then Sue will talk a little bit more specifically. And then or I should say CAMD provides comprehensive behavioral intervention through a contract with Hawaii Behavioral Health. And we'll hear about the data from CBI from ADA, and then Kat will talk a little bit more about CBI. Another direct service that we will be providing that is not happening just yet, but we've been working on the process of, is our multidisciplinary evaluation team, and that's for youth with complex needs. But we'll have more information to share about that soon. Another area of focus is informing the development of policies. So Project Laulima sits on the HISYNC committee, the Hawaii Interagency State Youth Network of Care Committee, and we're in a nice position because we are allowed to share a lot of the work that we're doing around youth with multi-agency needs. So we are focused on a specific population of youth, but when we talk with the committee, we're allowed to really broaden that population to youth who have multi-agency needs in a broader perspective, in a broader sense. And then last area of focus for us is evaluation. We're kind of continually evaluating that the work that we're doing, our programs, our training. So I'm going to first talk about community outreach. And so this is not by any means an exhaustive list of the work that we do, but we do a lot of work around children's mental health awareness activities during the month of May. Our staff member, Nicole Bell, sits on the Children's Mental Health Matters Campaign Committee, and they do a lot of work around Children's Mental Health Awareness Month and planning statewide events. And we always go to the Malama the Mind event in Hilo during the month of May, and we've been active with that particular event. We do a lot of other community events. We've had sessions at the Learning Disabilities Association's Traveling Mini Conference, the Special Parent Information Network Conference. I see Amanda and Sue in the back. And have had a presence at a bunch of different health and wellness fairs across the state, and have been doing a lot of work around bullying prevention. Sue sits on a bullying prevention task force, and we've also partnered with the Hawaii Youth Services Network to develop a culturally relevant bullying prevention video, and that is to be their initial vision for that was that it would be used for the Parks and Rec summer programs, but now we have the ability to kind of disseminate that work broader, disseminate that work on a bigger scale, and that actually should be done soon, so that's been an exciting project that we've been a part of. So in terms of training and capacity building, during our initial planning year, we met with a lot of different agencies and organizations and talked about what the training needs were going to be. And the training kind of fell into three primary areas. One was on cross-systems training, so having individuals from across the system coming together, building partnerships, and doing work around collaboration. So that was one thing that we knew we wanted to do when we received implementation funding. Another area of focus was implementing some skill-building workshops for families and also doing training for providers. And, the categories for training weren't really they're not really black and white. We do a lot of workshops where we are, where families and providers come together. But those are the audiences for the trainings that we wanted to be sure that we included with our training programs. So in terms of capacity building initiatives that include families as well as providers, we have developed a professional learning community on co-occurring mental health and intellectual and developmental disabilities. I'll talk a little bit more about that in just a second. So our cross-system training on collaboration, as I said, this was conceived of during our planning year. And this has actually been a really cool, I think a really cool initiative of the grant. And we worked with Dr. Jenny Wells from UH Manoa in the special education department to come up with a curriculum about how to better connect people within a community and to increase collaboration. And we came up with a kind of one-day in-person training, and we piloted the training in East Hawaii in November of 2014. And what the training was really focused on was asking the community to identify priority areas, areas that they felt could be strengthened in terms of collaboration. And we kind of addressed some of those issues through facilitated discussions and interactive activities and did a lot of like really fun just networking stuff. And people really liked it. So then we decided that maybe we were onto something, and we implemented in Kauai in November, then Molokai this past February, and are doing one on Maui in September. And the framework for the events have been very similar in some respects, but we've worked with each community before the event to ask like what the needs are and what folks want to focus on. So each event has been kind of tailored. Kauai, for example, was really interested in issues related to resource coordination. And so one of the outcomes from that particular event was to do a resource fair, and they're actually doing that next week. So after the event, people were really energized. They've been working together, doing a lot of cool work, and then they developed a subcommittee, and they're putting together this resource fair. Awesome. In East Hawaii, folks are really interested in getting a group together to do some ongoing work and talk about issues of collaboration at the local level. So after our meeting, folks have been, they call it the Mental Health Quality Assurance Group, and they've been meeting monthly since then. So the outcomes of the meetings have been different and kind of depended on the groups involved, but people have really liked this one, and it's been a really a cool event. To go along with the cross-system training, we developed an interagency information portal on, it's a Blackboard site, and we have a course called Hawaii Collaborates or something along those lines, and we have a bunch of information about all the child-serving agencies, Canopy, Developmental Disabilities Division, DOE, a bunch of different organizations, and just have information regarding services provided, eligibility, because during our planning year, we heard a lot from families that they just couldn't find this information online in a really easy way. It would be embedded in websites, and the formatting is different, and so the information was hard to find. So we put it in one place. All of the information is laid out in the same way, so folks can just click on it, find more information about services and eligibility information that way, as well as providing a bunch of different professional development resources as well. So that's something that we started a couple years ago, but then we didn't really put the word out enough. And so now we're really trying, because we're approaching the end of the grant, and doing a lot of capacity building stuff to get the word out about that. That's the site. I think I probably have to move a little faster too. So that's just, you can click on the link and find more information about each agency. The next thing we've been doing in terms of training is developing a professional learning community on co-occurring mental health and IDD. And in order to get this learning community started, we partnered with the Center for Start Services, which is an organization based out of New Hampshire. And they've been doing work with this population for almost 30 years and have a lot of amazing resources in this area. So we partnered with them to have access to the resources that they have, webinars, trainings, all of that. And we enrolled 50 individuals from the system to be in the training, in the learning community. And we've got individuals from different agencies, different roles from across the state. And there's been some issues with that, just the rollout of that, but I won't get into that now. But we just had our first in-person meeting with 32 of the 50 people enrolled in the learning community on Friday, and it was awesome. So that's been a really great initiative. So we just share, the same approach that START does, doing cross-systems collaborative work, and a lot of what we're doing is to build community capacity. So I won't read through this because I know we have a lot to get to, but we've put on a lot of training events with the program on a host of different issues: fetal alcohol spectrum disorders, adapting mental health treatment for children and youth with intellectual or developmental disabilities, sexual behavioral interventions. We've done work on stress reduction and bullying prevention. So we've done a lot of, had a lot of really interesting trainings over the past few years. Now, in terms of our direct services, so one of the services that we provide kind of in-house is our Solution SUI, and this is our multi-agency teaming process. And this is a process really focused on helping families to identify any system barriers that they might be experiencing. A lot of what they tell us that they need is kind of better coordination, and a lot of them are working with a lot of different agencies and organizations, and they kind of really like that we bring everybody to the table to kind of problem solve around some of those issues. And resource identification is a big one too. Sue will talk more about this in just a minute. Our next service that we offer through CAMD, I guess you could say, that we, helped conceive of and bring about, is comprehensive behavioral intervention. So this is a specialized service that's modeled after CAMD's intensive in-home service. It's provided statewide and accessed through the Family Guidance Centers. HBH, Hawaii Behavioral Health, is the provider for the service, and what's really exciting is from the very beginning, this is something that Dr. Michaels and folks at CAMD said that would be sustained after Project Laulima's funding was complete. So that was kind of an exciting thing because we heard a lot from families about, grants bringing up programs, and then, after a couple of years, the program being gone. So knowing going in that this was something that would be sustained by CAMD was exciting for us. Pat will talk a little bit more about this, but CBI includes behavioral and therapeutic interventions, paraprofessional support services, and we've done some specialized training with HBH, and we have folks from HBH enrolled in our professional learning community as well. So in terms of informing policy, we work with the HISTING, which I just defined earlier, Hawaii Interagency State Youth Network of Care Committee, which is comprised of leadership from several child-serving agencies. I think I forgot DDD in that list. CAMD, Child and Family Service, Child Welfare Services, DDD, Department of Education, Early Intervention, Office of Youth Services, and the Judiciary. I hope I included everybody. And like I said, we're allowed to, or kind of our role, I think, is to really talk about the initiatives that we've implemented for youth with multi-agency needs, so the group can really think through, how that might be applied to other groups of youth with multi-agency needs. And lastly, for me, so we are evaluating everything that we're doing all the time. For our Solution SUI, we administer surveys to the youth and families that are involved in the Solution SUI to get feedback about whether they thought the meeting was helpful, if it addressed the issues that they raised, and the reason why the meeting was held. We also have surveys for the other participants in the meeting as well. For comprehensive behavioral intervention, we have SAMHSA required data collection for our services that we conduct. And then CAMD's performance monitoring group is also doing a lot of work around quality, assuring quality of the services as well. We also have additional SAMHSA required data collection. Some of the things that we have to report to SAMHSA about is the numbers of folks from different agencies that are collaborating, if we've developed any policies through the grant, what types of workforce initiatives we've implemented, and how many individuals have been trained through the program, family and youth participation, how many folks are we working with that are family members or young adults. So there's additional stuff that we're collecting for SAMHSA aside from the services data. And then lastly, we administer surveys at all of our training events and workshops too. So that's it for me. The next thing we're going to talk about are specialized services. Sue is going to talk about our solution suite and our specialized consultation.
About our specialized services, and one of the things that we started off with was this idea of having a solutions HUI for those families that were experiencing difficulty accessing services or struggling with finding the right fit. So this concept kind of evolved during the first year or two of the grant, and then extra position was created in order to really give it the amount of attention we thought that it would need. As we moved along in the process, though, the idea initially was that we would perhaps get referrals from the family guidance centers, and that's sort of how it started. And then as we spent time going out into the community and talking to people, we started getting questions from community people. And so some of these might have been in person when we were doing presentations about the project. Some of them, we always include our brochure and say, please follow up with us. So we've got phone calls sometimes from teachers, from SBBH providers, from different community providers. We got a few from parents who actually heard about our project through our outreach and our information tables. And so we thought we would kind of formalize this a little bit. And so this is what we're calling our specialized consultation. So people would generally call, they'll say, I have a youth, I want to know if their Project Laulima can help this kid. And so we kind of do a triage on the phone, get information about really what their issues are that they're concerned about, and depending on who that person is, we'll have different emphasis of focus. Find out if that's a youth that might fit Candy's criteria for services. That's one important thing. Whether or not they fit Project Laulima's target population is another important thing. If they're looking for services that seem to be within Candy's scope of service, then we would refer them to the Family Guidance Center, because that's where the intake happens and all those decisions are done at that level. And it's important that families know that, or providers know that that's the process that they go to. So it might be at that certain point in time giving them the Family Guidance Center number and asking them to follow up with the Family Guidance Center. Possible CBI or 13101 if that's a youth that doesn't fit in PL's population. But we don't want to assume that we can give people that kind of specific information over the phone, so we make that referral. And we're pretty clear about that, I think, when we go out to the public about telling folks that this is the process if you're interested in those services. So there may be some people who are also calling about the systems issues and the systems barriers that a solutions HUI might help them with. And so that would maybe then take us to like a next level of discussion. And if we're thinking that calling a team together is something that might really benefit the child and the family, we really want to connect also with the parent and make sure that this is something, they're a crucial part in this engagement process. And of course, getting consents. Getting consensus being kind of a challenge, because when we're talking about multiple agencies, we're talking about a lot of time in collecting that kind of information. The other alternative might be that we may have some families that just need a referral. So I may say, you should call SPIN, or you should call the Learning Disabilities Association, and giving them some suggestions of community resources that they might not have connected with. If it's a provider calling, they may want to share that information with the family that they're working with. So, we have multiple ways we can kind of do some triaging, kind of support, giving them some alternatives. And I always do ask people to let me know how it went and call me back if you get stuck, because I think that's an important piece of things. So what does Project Laulima do to help support this? So we have staff that serve as resources. So Nicole Bell and I work pretty closely together with doing the solutions HUI. Nicole will do the family interview to really make sure that we are addressing the family's needs. I will help kind of pull all the records together, do a record review, and then we work together collaboratively to kind of generate what we think this picture looks like and what other information might we want to have. And that's sort of how we're facilitating that interagency collaboration. Sometimes we find as we start on the process that that's really all it needs. We've had some situations where we've had phone calls and it really was, somebody was stuck where they got, one agency didn't move on their request, and sometimes just making that phone call and saying there's an interest in having this is enough to sometimes kind of get people to jump into action, which is a really easy solution for us. It doesn't require a whole meeting in order to accomplish that. So the solutions who we team members, if we get to that point where we're doing that, would be those folks who are already working with the youth and the family. And it might also include agencies that maybe we're thinking might be potential providers or could be additional resources to the family. So that's kind of the unique aspect of being able to maybe pull people in who, might be the ones that connect them with, that they aren't connected with already. We have a list here of some of the folks that, maybe it's not on this slide, but on the other slide, that might be involved. And then the other plus for doing this meeting, which makes it a bit different from other team meetings, is we also have this opportunity to include our CAMD psychologist, which is Leslie Slavin, our DDD psychologist, who's Chanel Kealoha, and they can actually sit in and provide some of those administrative questions and those policy questions that are sometimes at the root of why some of these kids are stuck. And sometimes they can also serve as a third person. They're taking a fresh look at this kid. It's not that nitty-gritty day-to-day, can't see the forest for the trees kind of approach. And so that has been extremely helpful, I think, not only for the team working with the youth, but also for us of having some more expertise to provide some on-site consultation on a real-life case. And that's been extremely helpful. So our outcomes, I think we've talked a little bit about already, to look at the resources, serve as a coordinator. And then some of that information we gather from the meetings then can go to the high sync group as well. It also helps us understand where the policies that are in place are maybe really the pieces that are the problematic sources. And so having that information has been helpful. So we do have a handout which kind of has the process on here. So you can, and this is a handout we provide when we do all of our information sharing that kind of goes over the process a little bit. So I don't think I need to go through every single one of these steps. So we identify the folks, we get the consents, we spend time really talking to the family about what they see as the problems and the issues and the barriers and really get their perspective. And that is all written up, as that interview is all written up. The other thing we then do is send that information out to all the team members prior to the meeting, including a summary of what we've gleaned from the records from the different agencies, looking at the services the youth is currently getting, so that all of that's compiled into one document. So before the team meeting, everybody has access to that. So we thought to make it real, we would create a real youth scenario for you. This is based on putting some of our different experiences together into one particular profile. So we decided to talk about Keone, who's 16 years old, who lives with his mother and two sisters in rural Oahu, and we're finding that we have a lot of issues for rural kids, and so that's important for us to think about with accessing services and eligibility. He has some underlying health problems. He receives special education in a fully self-contained classroom. So we're not actually talking about a specific IQ right now, but I think our population is children and youth with mild to moderate intellectual disabilities and a mental health diagnosis. So since this youth is already getting CBI in our scenario, we know he fits our target population. He's getting in-home intensive behavioral intervention services at home to address his escalating aggressive behaviors. This is mom's issue. She wants to get help, and that's really what we hear from families. And the Family Guidance Center coordinator suggested a solutions hui meeting. So the interview would look at the strengths and needs of the youth, and then the systems, barriers, and issues that the family's facing. And so this is a little bit of a snapshot based on our pseudo interview with mom about Keone. And what we're really looking for here is, what are the things that jump out for us? And I think you guys are all in the field, so you probably can take a look at this, and you've probably already got some ideas in your head about, this is a kid who maybe we need to think about X, or this is a kid who maybe we're thinking, maybe we want to know a little bit more about. So this is sort of a typical idea, information we get for families, and then we kind of go back and see, like, what else do we need to learn about the situation? And then we really want to end up with really having mom clearly, or the dad, or the youth if they're involved as well, really identify things that they'd like to see as outcomes for having the meeting. And that's really important, because we don't want to just have a meeting to talk about things that the team thinks are relevant, because we know those meetings take place as well. This is an additional meeting to also help see how are those care plans fitting in with what the family wants to have. So the team is planning on meeting. We'll sit down with them. We will review the written information that we sent out, and then we're going to really identify the goals. So for this particular youth, respite support is something mom is looking for. So we're thinking, okay, if he hasn't already been connected with DD, is this a youth that maybe we could help with that connection? And this has been true of several of our solutions buoys that we've done. Mom's identifying she's getting hassles from the school because he's missing school. She's got hassles with him, behavioral issues because he doesn't want to take his medication. He's got asthma. So we're thinking, is that well controlled? Is there any underlying health issues that maybe haven't ever really been identified? And then she's also concerned he's not making academic progress. And we know for kids with intellectual disabilities, especially if they're getting into the teenage years, you may be starting to kind of see a real slowdown in their academic skill acquisition. But we kind of want to know too, is there another reason, is there a reason for this, and what else might we want to look at? And because he's 16, we do have to start thinking about, okay, he's going to become a young adult, guardianship issues are probably kind of lurking in there somewhere, and also transition issues. Is this a youth who's going to be able to live on their own? Are there things that we need to do to think about that? Have they been connected to vocational services? And that would all be something that probably would need to take place at an IEP meeting. And we don't want to make those decisions at a solutions buoy meeting, but the idea might be to at least kind of bring them up and think, where would we go from that? So during the meeting, we identify action steps, and then we really also try to see who is going to take ownership for each of those action steps. So for this young man, the CAMD care coordinator is going to help the mom with the DD referral process. Mom is going to follow up with the health issues, because when we took a break and we kind of met in between, we were thinking, these ear infections, these allergies, maybe these are health issues that are also impacting on his learning. What about his hearing? If he's had a history of chronic ear infections, has that impacted on his hearing ability, or is it on and off because of fluid or ear infections affecting his hearing? So those are some things we would suggest mom follow up with the physician. And then we usually have somebody from the DOE also at the meetings, and it might be that would be a time to say, okay, maybe these are some of these academic concerns can go back to the IEP team, and then the school can hold an IEP meeting to follow up on that. And then one of the issues that sometimes we find that not all of our families have connected with a parent partner through the family guidance centers. And for families, maybe single parents or parents that are struggling, they really feel alone in that process. And then maybe connecting them with a parent partner would be a positive thing to help them, support them, and reduce some of their experience of frustration. So the plan is then to connect Patty, the mom, with the parent partner, and then also look at how could we address transition and independent living as we look at future planning for this young man. So everybody in the service providers would kind of have that on their radars moving forward for him. So we're going to have a happy ending for our young man. So 6-month follow-up. So the mom is now working with the family guidance parent partner. We learned that Kyung actually does have a hearing loss that never was really identified. So now we've got an action plan for looking at that. It's also helping us understand about some of his aggressive behaviors, that perhaps there was some other underlying issues, not just cranky 16-year-old adolescent who wants his mom to leave him alone and is, taking it out on his sisters. And so CBI is now kind of been looking at addressing some of those issues, and that modification is helping him have more success. He's found eligible for DD, so we can look to DD for more supports with possible respite, and also looking at independent living skill acquisition that really might help with him having more options for the future. As far as our school absences and academic progress, so the doctor was able to provide mom with a letter to take to the school so that they understand about his frequent absences, so they're not just thinking he's truant and cutting out of school, which has probably helped relieve some of her distress. That information is also now included along with his hearing loss in his IEP, so that people are aware of that when they're addressing his needs. Found out he's allergic to his dog, so even though he loves playing with his dog, that was a problem. But now he's using a prescription nose spray to reduce his allergies, and he's getting support. CBI is also helping look at medication compliance, which was an issue mom was trying to deal with on her own, and so that's not something that she can get more support with. Okay, and then now that we know he's got a mild hearing loss, there's an FM system provided in the classroom, and teachers starting to see improvement in him following directions. So we may not see academic skills improve a lot, but at least we're seeing that now there's some supports in place and there's a better understanding. Maybe the teacher will be making sure she's making eye contact, and that those directions are received. And so those are going to be some positive things. School's also looking at doing a reevaluation based on some of that information, and also looking at maybe for some of these kids, they don't necessarily get a cognitive and an academic reevaluation as frequently as they get into 16, 17-year-old. They're kind of going based on previous evaluations. If it's been a while, it might be time to do a re-eval given that they've got new information. So planning for the future, that transition plan now has DVR in there, and we're going to make sure it gets connected to DVR, and that those independent living skills get addressed in all the different service plans that different agencies are providing. So we decided after the 6 months that the Solution Hui meetings goals, and we met those goals and they've been addressed, and he's going to continue to be followed by the Family Guidance Center, and they'll look at whether or not to continue with CBI or look at some other support services. Happy ending, huh? For hearing. Thank you. And Ada will be following up with CBI.
So this slide just tells you like that I'm working with like different data sources. It's sometimes a little bit hard because you know, I'm trying to match like all the data that I'm getting, and sometimes it just doesn't match, and so I have to like go to different sources to make sure that I'm getting all the correct data. And this is like just another call for this like centralized CAMD database. That would be great, so you know we don't have to like go to like different sources to like get to the data. Here is just a quick overview of enrollment data and discharge numbers. As of today, we have 53 kids who have been enrolled in CBI. And of those 53, there are 2 who have been re-enrolled, which means they started CBI services for the first time sometime last year. And then they were discharged, and they came back and now are back into CBI. One I just got the notice last week that he is now receiving CBI services again for the second time around. And of those 53, 14 have been discharged so far. On to age groups. So the table just gives you like age groups, but I thought it would also be a good idea to just give you the individual age breakdown for those who want to like get the exact details. And the average age of those who are currently in or who have been receiving CBI services is 11 years.
That's kind of amazing considering the age range for regular candy students, which are much older and have an average in around 14.
Yeah, it's actually surprising when you look at like the individual age breakdown. We have like 2 who, when they got admitted, they were only 3 years old, which is, you know, a big surprise. And one of those really young ones, she was receiving CBI services last year for the first time, then got discharged, and now she is back. But she is doing pretty well so far as I can tell from like some of the things that I've been reading. So, which is, you know, really good that kids get services now at such an early age and getting the help they need. In terms of gender, there are about twice as many males as females in the program right now, and it's not really a surprise. It seems like it's like the same for other CAMD services. And likewise, in terms of ethnicity, a lot of them have multiple ethnicities. And you can see, for example, there are 3 who claim 5 ethnicities. So it's a very multicultural, multi-ethnic group that's receiving CBI services. In terms of location, most of the kids who have been receiving services are on the Big Island. And on the Big Island, especially Hilo, there have been 14 youths who have been receiving services over there. But throughout the state of Hawaii, you know, there are kids receiving CBI on every single island. Big of a surprise is Leeward. We were thinking that there would be more CBI cases on that side of Oahu, but only 2 so far, and 1 has been discharged. So currently, there's only 1 on the Leeward side who is getting CBI services. And I thought it would be interesting also to know like the urban-rural breakdown. So definitely, most of the kids live in more urban areas. There were 6 in rural areas, and they're all actually on Maui. Which to me was a little bit of a surprise. I thought they would all be on Big Island, but turns out they are on Maui. Another interesting find was the services that kids received before starting CBI services, and about half they have been in Camden for quite a while. There was one who's been in Camden since 2002. I'm not sure now if this child has been receiving services throughout, or you know, like started getting services, then not, and started again. So I would have to look into that a little bit more. In terms of getting services right before starting CBI, there were 20 who received intensive in-home therapy, and then a few others who received other services. In terms of CBI referrals, so Project Laulima started in January of last year, and the first referral came in March of that year. And since then, like, referrals have been fluctuating. There were a few months where there were quite a few, and then there are other months where there's only 1 or none. For example, like in March of this year, there was no referral at all. And I talked with Michelle at HBH, my contact, and we like tried to brainstorm a little bit as to why that would be, but we couldn't really figure out. So if anybody has suggestions or input into that, that would be great to know. In terms of diagnosis, I looked at the primary diagnosis, and a lot of the youth, they have ADHD and pervasive developmental delay. Yeah, pretty self-explanatory as to like the diagnosis that the children have. And so far I don't have all of them. A few are missing, so some are not yet available. So I will add those on as they become available. In terms of discharges, I mentioned before that 14 youths have been discharged so far, and 5 on Hawaii, 1 Kauai, Maui 6, and Oahu 2. And on the right side there is a breakdown. Oh, well, the numbers disappeared. Okay, sorry about that. I thought they would be on there, but they're not on the slide, so I will add those on. And the length of time that children have been receiving services varies greatly, between 15 days and 278 days so far. 15 days, I remember that was a case where that child just did not fit the criteria. It was because of the IQ was way too high, so the child actually did not really qualify. I noted here the reasons for discharge for all those 14. So 2 youths, they did not meet CBI criteria. 2 actually met the goal and were discharged successfully. 5 youths, unfortunately, the caregivers, they did not want to engage any longer. They refused CBI services because they didn't want anybody to be in their home, or they just thought that CBI was not the right service for their child. And 4 of them required a higher level of care. So there are some pretty tough cases who've been receiving CBI, and CBI was just not the right level of care for them. And for 1 youth, unfortunately, I couldn't find out exactly what the reason of discharge was, so hopefully I will be able to do so, and we'll add that on at a later date. For higher scales, this is very preliminary. I don't really want to go into detail yet, just because I still need to look more at the data and kind of dig into it, see what's going on really, and yeah, that's why I just don't want to really talk about it yet. The last slide here is just a summary of what I just told you, just for you to like review and quick view, and just to also let everybody know data collection and data analysis is ongoing. So if you have any questions at this point or later on, please let me know. There's a lot of data available, and I've only presented like a small portion of it. So, that's just to let you know that's way more out there. So let me know if there's need for any of the data for any of you. Thank you.
How the program is different between 13101 and CBI.
Define 13101, because there are people that are in our system.
So we have intensive in-home services, and basically it's a short-term service, but it's all based on the need of the child. So it could be 3 to 6 months, sometimes up to a year, depending on the needs. And then it would be the therapists work with the families based on the referral goals, and it would be intensive. It's about 20 hours a month, working on the goals with the family about 2-3 times a week, with the end goal to transition them back to the school therapist or an outpatient therapist. Because that would be intensive in-home. So for CBI, the additional criteria would be the eligibility requirements and the additional diagnosis with developmental delays for the 2. So for us, the successes that we've noticed, in the beginning there was a challenge, I think, with getting all the data, meeting the deadlines. And so that's gotten better. I think with Michelle and Ida talking regularly, that's really been streamlined, and our deadlines more consistently met. And with the families, most of the families participate in the intake and the exit interviews. So that really helped us gather more information and see how we're working with them and how we can benefit. One of the biggest successes is the flexibility. Because we provide the services across the different islands, one of the cases that did come up was what that you spoke about at the training on Friday. We had a kid that was in the hospital, and one of the goals was to get him back home on a neighbor island. And the challenge was helping him start the process while he was here and continue on when he did get home. And so what we did was we had a therapist provide that service here. And so he was able to work on some goals in the program while he was on Oahu. And then when he went back home, he could meet with his CBI therapist back home, and regularly, between the two therapists would discuss what they were working on. So that really helped his transition back. So that was one of our big successes, because I know initially there was a challenge about how he could start working on those goals here before he could even leave the program or leave the island to get back to the other island. The different challenges that we have faced, one would be that not all the family guidance centers were aware of what the requirements were or the services that we provided. So that often meant that referral would come in and it could qualify as a CBI referral, but because the family guidance center wasn't aware of the different requirements, they came in as a 13101 referral. And so sometimes that had to be changed. So we already did the intake, and then we had to transition them to CBI. Another one would be hours authorized. There was some confusion going on also in the beginning with, I guess, how many hours can be authorized. They had to go through utilization review. They had to get permission to get the paraprofessional, even though we were trying to explain that that was part of the program. So that was another challenge that we encountered. But those, I think, when you guys did the presentations, right, and you guys had presented that to the Family Guidance Center, that had gotten better, where they were aware of what we were supposed to be working on and how to send the referrals in, so we could have one referral and they didn't have to go through sending multiple authorizations for paraprofessionals or for the 13101 therapists, 13103 therapists. Trainings-wise, we also have a variety of trainings that, well, I guess going back, the difference between 13101 and 13103. For our therapists, there's not a whole lot of difference because we expect them all to attend all the trainings. So if you were to compare intensive in-home therapists from Hawaii Behavioral Health to another agency, there would be some differences because they wouldn't receive all the trainings we have. We have ABA trainings. We work on different parenting skills. We work on different, having different prompting levels, or, you know, any kind of, sorry, I'm drawing a blank. Roma back there is our training coordinator. Can you help explain some of the trainings, Roma?
Which ones?
The last ones that we did, the ones that would help our therapists. Oh, thank you for the microphone.
Do I need to use the microphone? Can I just use the microphone? Do I have to use the microphone?
It might help for the
Well, in terms of, I would say the last few months, we've done trainings that have been sort of focused on autism spectrum disorders, but they've also been applicable and evidence-based to other sort of diagnoses that we see. Anxiety, ADHD, some behaviorally disruptive disorders. But we've done some, I think most recently on visual supports, prompting, chaining, some of those types of really sort of practical hands-on interventions that hopefully can even be taught to the parents as well, right? Because these are skills that are very important if you have a child who's struggling, you know, getting ready for school in the morning or being able to complete a task. You know, there are very simple ways to, or interventions to manage that. So we're hoping that with the trainings, not only are we training our staff, but they'll be more knowledgeable in terms of modeling it for other providers. And for the people that do have access to the families, or that's within their job description, they're able to teach those to the families and to the parents so that you know, there's a continuity of what is going on maybe in the school setting or in the home setting, and then what we're working on with the child.
And
so
I think,
it's a
oh, I was
little
gonna
more,
say
I
the
would say,
benefit-
global in
Yeah.
a sense. Yeah.
the benefits of the trainings that we have done not only work with our population with CBI, we also gave examples of how you can also utilize that for intensive in-home, because those are similar supports that the therapist can use with those youth as well. So the difference for our therapists, they're trained to use all the interventions and modify them as needed for each diagnosis. Because even if the youth doesn't have a developmental delay, the trainings that we've gone through and taught them, they can use for anxiety disorder or other needs that they have as well. Yeah. So those are the different trainings. Was there another part? Yeah, so that would be, so it would be the visual supports, the prompting, chaining, I I think we have different task analysis, breaking down the tasks to different components, and that's all individualized to the youth. So if we have some youth that need the components broken down to smaller steps, that can be done. But some kids, they're able to have bigger chunks for the task analysis because they're able to complete those steps. And like I said, those can be done across different diagnoses as well, not just for developmental delays. So in regards to our therapists that provide services, CAMD services, all of them are trained across all these modalities. And then we have a family that came to share. So Beth, thank you. I don't know whether you want me to talk to that. How the program's been working for you, challenges. Oh, actually, I'm sorry, can I do one more thing? Sorry, there was one more thing that I was gonna bring up that was a challenge. In the beginning, some families were not aware of what our services were, and our services were confused with DD services or PAP services or respite services. And that was another big challenge that we had to overcome, to work with the families to realize that the services that we were providing were to achieve goals to help them, to meet their needs so that they can be more independent, that they can be in the home and have more structure. And some parents were thinking that we would be there to pick up the kids after school and take them to activities. And that took a while. So there were some families that they didn't understand what our services were. And so we had to work on that with the care coordinators. But thank you, Beth, sorry.
Excuse me, I've got a little bit of a cold. The services, the CBI services for us have been really life-changing. And we've gotten services of some kind or another for many years now, but they were really just, a pressing pause, where I just got to take a breath while someone was there and, they would play cards or do something with my daughter. But, it didn't go much beyond that before. And I was very grateful for those. I needed those moments of pause. But the difference with the CBI services is that, our CBI therapist, came in, she spoke to me, we, debriefed what the issues were at this moment in time, not what they had been in the past, and we, came up with a plan, and it was very methodical about how we're going to address each one of these issues, and it's been really thorough and complete, and so just the, going to the grocery store I used to tell people I'd rather, be boiled in oil than go to the grocery store. But they worked on it. They went to the store. They had, tasks. You're going to go to the store and you're not going to, eat one of the treats that they're offering at Whole Foods. And we're going to go to the store and, I'm going to hold the cart, not you. And just all these things that used to be challenges. There used to be 800 power struggles in a grocery store trip. And now we go to the store and we don't need a therapist with us, and I can say, no, you're not going to have the donut treat that they just set out, and we can manage that. And before, I couldn't even imagine going to the store where they are putting out food and getting through that trip. So just a simple thing like that has changed, completely since our CBI services have started. And that was just one of the things. And so, once we conquer the grocery store, then it's on to the next, hurdle, the next mountain. Okay, we need to conquer, how we deal with, managing homework or getting up in the morning. And it's not always the therapist doing it with her, and then I see the benefits. Sometimes it's, what do I do about this morning? I can't get the child out of bed, and then we talk about it, and sometimes it's a solution that I should have thought of myself, and I just needed to have somebody to talk to, and sometimes it's like, I never thought of that. Let's try that, and yes, now the child, we're getting out of bed without a big battle, and so it's each of these things, before we just never had a plan and a methodology and a way to be goal oriented and to get through these things, so yeah, I'm so grateful.
And in adding to that, like what Beth was saying, when the therapists go in to work with the families, they're looking at what the family's strengths are, what their needs are, and how to support them. Build on the strengths to work on the goals. And so like Beth said, like oftentimes the families already, they know what they need to do or what should be done, and we support them on how to get there. So the challenge in the grocery store, then we work with them and the youth on the steps and work on coping skills or different ways to set structures, or even having reinforcers so that they can achieve that goal where they can go in the grocery store and they're not gonna have a meltdown because they're not getting the item they want. And it could be that, you know, we set up some kind of reinforcement system where they're gonna get something else that they prefer way better at home than that small reinforcer at the store. So oftentimes we have parent training to work on those goals. We also have different stress management trainings for the parents. One of the biggest things that we want parents to know is that they need to take care of themselves first. And they need to, because as parents, right, oftentimes you're burnout, you're taking care of the child, and you need to take care of yourself first. You need to make sure that your needs are met and that you're in a good place. Because when you're in a good place, then whatever happens with your child, you're not going to react in a negative way. And so our therapists always want to work with the parents to make sure that they're taking care of themselves, that they're nurturing themselves so that they don't stress out and they're able to be consistent and structured with the youth in the community or wherever, whatever the goals are, whether they're at home or outside.
So, I guess I'll do a little moderating.
Thank you so much. Thank you so much for coming. It's just really helpful to
Didn't catch your name. I'm sorry? Beth. Beth, thank you so much for sharing your experience. If you mentioned that you had received services prior to CBI, yeah? I was wondering if you would be willing to share some of the differences between the CBI services that you received compared to others prior.
Sure, yeah, and I don't want to diss, the services we had. I was very grateful to get them at the time, but, in the past, the therapist would come and
she would play cards, and they would do small activities in our home, and they were all, they were good, they were relaxation, and and if something came up in that moment, she would help say, okay, we don't say it this way, we're gonna say it that way, or but it was very limited, and it was very much just whatever came up in the activity that they had planned to do in that moment. And there wasn't much of the benefit from that time, that hour they spent together. I didn't see that elsewhere once the therapist left. In fact, I used to hold my breath. The therapist leaves and we're going to be back to where we were. And it's different now. So again, because it's so methodical, it's very well planned out, and we work on one thing at a time. And if the thing can't be accomplished sitting in our living room, we go out and we do it where it needs to be accomplished, right? So again, do it at Whole Foods, or we go to the library and get through a homework assignment without the limits. So then I can see the benefit out in the community. We can get through these kinds of things, and then our life isn't so small. We can get out in the world and see friends and go places and do things, because now we have this many more skills to accomplish those things. So that transfer of what the therapist does with my daughter and what needs to happen in the rest of the world, it's right there. It's a smooth transition, and it's not just, okay, we managed to have a peaceful hour while we're together, and that's all really we can, it's all we can really do. So that's, and maybe that's unfair, but it seems like to me that there's a lot more transfer.
I really meant to say when I introduced the panel that, there's not a lot of tested evidence-based services for youth with co-occurring developmental disabilities and mental health problems. So you can't just look that up on the blue menu and figure out what to do. But to me, this sounds like you're getting evidence-based services now around behavior shaping kinds of interventions, and what you were getting before would be less evidence-based. So it kind of goes with the purpose of this committee. Who else has a question or a comment? Brad.
Nobody else was on it. Thank you very much for the panel. One question I have is, with all of the different service agencies that are involved, I guess, how does it work with care coordination? So is the CAMD coordinator like the super duper coordinator? And like, I mean, how does that work? If people would speak to that, that'd be great.
Yeah, so it's basically like other CAMD youth where there's a care coordinator in the Family Guidance Center. But when we wrote the specs for comprehensive behavioral intervention, we did talk about expecting the therapist to do more care coordinating than you might in a typical mental health case. Partly because a lot of the youth need a lot of supervision, and there's a lot of like, who's gonna pick them up when, and what are we gonna do during this half hour? And having care coordinators in the mix is sometimes just more cumbersome. So, I don't know, that's sort of what we wrote. Kat, maybe you could.
Well, yeah, so I was gonna say, the therapist would be the one organizing the schedule. So the therapist works with the family, does work with the youth, but we have a paraprofessional that implements goals as well in the community or at home, depending on the need. And so the therapist would do most of that care coordinating, where they're scheduling it, they're following up the parents, making sure it works, with the paraprofessional on what's being done. We have data taken on the goals that are being worked on wherever they're servicing the youth. And so the therapist would be the one collecting the data, analyzing it, and following up with the care coordinator, the family, and then again, working with the paraprofessional on the changes or to address if there's any needs that need to be changed, and implementing the program based on the data that's been taken.
Thank you all for sharing. It's really helpful. And Beth, I'm glad you're getting some tools at home, and that's really fundamental to family quality of life. Do you see any coordination between home and school? Is Project Laulima helping you to share your newfound insights about your daughter's behavior with people at school?
This is the last piece, is getting the school settled. And in fact, I had an IP meeting this morning, and I always have to, do some yoga or something after these meetings because I'm so upset usually. So yes, and one of the things that today came up was, if things are very dysfunctional in the school, and the excuse for that happening is that she's not capable of doing better. Yet out in the community, we were having difficulties, and now we're not, right? And so we're not having the kinds of behaviors that they're talking about in school. So that to me, and this is what I brought up this morning, that speaks to approach, right? So it's not that she's not capable of doing what you need her to do. We need a different approach. And, and I actually said what I said this morning, like we had, just having people on her is not enough. There has to be a system, and has to be an approach that's working. And if it's not working, then we need to tweak it and not just blame her for that. And I mean, I'm hard on her too. Like, when I'm talking to her, it's like, you need to do what you need to do at school. I don't want to hear about so-and-so said something to you. But in the IP meeting, I'm saying, if she's able to go from this to this in the grocery store and this to this in the library, she should be able to go from this to this in a language arts class. Yeah. And so, that was the next, actually we wrote it in the IEP. The next step would be to make sure that our therapist is working with the school staff so that they could, share what has been successful with her in the school setting. Because if one piece of the puzzle isn't working, as as gifted as our therapist is, you know, she's not going to be able to maintain that if things are falling apart somewhere, right? So we need to get home and school and community all working together, you know. So otherwise it just can't sustain it, and we can't get the goals, the gains that we need to get.
I just want to ask if anybody on Zoom or UTC wants to ask any question. Okay.
Were you able to hear us last night?
Yes. Now we can see you, Madeline.
This is Madeline. I was wondering if we would be able to get the handout.
Yes. And I think we're gonna post it to the Help Your Kidney website.
Yes. Nice. Oh, I'm sorry.
Hi, thank you for sharing. I was just, I guess this is something that comes up in peer reviews and triage is, I hear about Project Laulima a lot, but the problem is, how do we connect to you guys from DOE? Because I'm not sure if you guys are listed under DOH, and there's like someone who whips their magical wand, like send them to Project Laulima, or they just automatically go to something else. Like, and then what else is the requirements? Because I think that's the systematic issue we're facing, is trying to get to you guys. What is going on? Like, I don't know how to refer to you guys at all, or find you guys.
No, I thank you for bringing that up, because it is a question we get a lot when we go out into the community. And I think that some, you know, especially as we're entering the last year of the grant, so there's a sort of idea that Project Laulima is providing these services, and really when it comes to CBI, it's really through the Family Guidance Center, and it's HBH who's our provider. So I think that's really an important consideration, and the process for accessing services is the same as it would be for 13101 intensive in-home. So really that needs to go to the Family Guidance Center and the intake process. So I don't know if that helps, but that's another piece of it. Did that answer your question? And Gina wants to add.
I just also want to say that I think that I think you speak to one of the challenges that we have had as a program, because I think that, like Sue said, you know, CBI is a contracted service from CAMD, that's a contract between CAMD and HBH. And so we do offer our in-house service, which is the Solutions SUI and our specialized care coordination. So I think people get really confused between those two things. And there's also another grant within CAMD, Project Calaho, and they offer their services kind of in-house. So I think when people know that there's another grant, they call and they say, you know, we want Project Laulima services, and then it becomes a little bit confusing, because it's like, do you want us to connect you to Sue, who's coordinating the Solutions SUI? Do you want us to connect you to your local Family Guidance Center and see if the youth could be eligible for CBI through CAMD or through their IEP? So I think that that's something we've actually had a hard time with from the beginning, and I think you speak kind of directly to that.
Yeah, because that's what we face. Like, when I bring up, hey, I have a student with a developmental disorder or a student with autism, the response I get is, no, we don't deal with that, and so forth. So it's just like, oh, but I just had Project Learning where people just come in and just tell me you guys do. And I'm telling them the Family Guidance Center, and they're like, no, we don't deal with that. So that's a constant struggle.
So you have to understand a little about the Child and Adolescent Mental Health Division and our eligibility criteria. So in order to be eligible, you have to have a psychiatric diagnosis. You have to have a mental health problem. That's what we're treating. And so youth who have mild intellectual impairment, but they have no mental health issue, can't qualify for CAMD. Youth who have autism and they don't have another psychiatric diagnosis can't qualify for CAMD. So really, honestly, I think autism has been the third rail of Project Laulima from the beginning, because there were decisions made long ago in the Felix era that DOE and DDD are responsible for autism treatment, not Child and Adolescent Mental Health Division. So it does get tricky around youth with autism.
But no, my students have comorbid 2 or 3 diagnoses. So I have one with autism, ADHD, and OCD, and another one with bipolar and ID. I mean, a low
Right.
IQ. So that's the thing I'm facing constantly, is finding services for them, and I'm constantly being told, no, you guys don't provide services.
Which guidance center?
Family Guidance Center, Central, Pearl City.
Central? Okay, well, call us. Dr. Ulrich, turn around, look at Dr. Ulrich.
But it's weird systematically.
Are you talking about youth who have Medicaid, or are they being referred through DOE and their IEP?
They all have IEPs.
Because if they have MedQuest insurance, it's a little easier. But they should be able to come into CAMD through their IEP if they have, say, OCD and a developmental disorder, or bipolar and a developmental disorder. So we could help you kind of appeal that with a guidance center.
Okay, so on your end, are you guys like talking to those people from Central District and doing trainings with them, let them know like, hey, we do exist and we are a part of you guys? Because it may seem like, no, that's something different.
Well, I mean, we've been talking about it a lot. Sometimes stuff doesn't get through. I don't know what to tell you. I think there are somewhat different eligibility barometers being used in different guidance centers. We are in the process now of developing, and it's going to be implemented this summer, a more standardized intake that should make that a little clearer. We're changing our eligibility forms, so that should be a little bit clearer. But in the meantime, I don't want your kids to languish, so those decisions not to take the youth can be appealed. So if you're getting stuck in, say, peer review, you could say to the guidance center people who are there, I want to appeal this decision. What do I do? And you can always call our medical director. And
Here.
yes, right here. Dan Ulrich, yeah.
Yeah, art division offices, yeah, but if there's a difficulty, I would always, take it up if something just
Yeah.
doesn't seem to be making sense that, should fit, and, there are, caveats, and it can be, as Dr. Slavin mentions, particularly around autism spectrum, when we're trying to diagnose co-occurring mental health disorders. That's really difficult to
Right.
tease out, and I think any professional or any family member, looking at it, sometimes there's going to be different interpretations. Indeed, is this a standalone mental health diagnosis, or is it really just part of the spectrum of the underlying developmental or autism spectrum? And I think that's still a real challenge just for the field that we're not at. But indeed, I think we want to try to work through it and have. There should really be some justification for why a particular youth isn't eligible, and then I think we should be offering. We want to connect with alternatives. I mean,
Right.
one of the benefits now in cases of autism spectrum is Medicaid and the commercial plans now have benefits and eligibility to provide services for that population. So those may be alternate sort of avenues to consider for treatment as well. But yeah, I think we're happy to discuss your particular cases because we can look into them and they may be learning opportunities for us.
Anybody else? Do you want to say something, Stan?
This discussion is helpful. And I want to particularly thank you, Beth, for coming in and because I don't often meet parents anymore. But concerning the problem of getting kids into the system, I think that is the whole point of all of these efforts of pulling the agencies together. I think that we have, for a variety of reasons in history, developed silos and definitions. Government is really good at defining and making rules about who can go where or who has to go where and that kind of thing. And so the solutions, Hui, and there are other efforts that we're making, the whole HiSync thing, which Pratima has, she's been very humble about her leadership that she's given to HiSync, and she really is the one that's been, because she's a lawyer too, if you don't know, she's been writing the MOA, which we desperately want to have finalized very soon, and to address this problem, because it is a systemic problem of how do you get agencies that have different budgets and different statutory mandates to work together when you have these human beings are a continuum, and they often have several problems, and several problems. Human beings don't categorize themselves, but yet we have systems that are very categorical, and it is very frustrating. But the point I want to make is the efforts that are being led by Project Laulima are not just the in-home service, which is great, but also efforts at breaking down these systematic silos which still remain 10 or 15 years after Felix. That's all I want to say.
Thank you. Well, I noticed that we're out of time, and I personally have to go. So maybe we can say thank you and give them a hand, and if you have